I'm going to turn on the Zoom recording. It may ask you to consent. It may not. This is for your use only.
Yep.
We usually have patients look at it again, probably a few days after we do the evaluation.
Yep.
Allows things to marinate and then crystallize.
Right.
And I'm going to share my screen with you. Full disclosure, I will move the mouse around the computer many times during this. That's just the way this process works, but we'll get there. So again, treat patients, not scans, not test results. Treat patients comprehensively. We're going to start with your total brain report, the first bit of neuropsych testing that we did in your case. And this is scored on a 1 to 100 scale, 1 being the far left end of the scale, most amount of symptoms, 100 to the right, the green zone, essentially symptom-free. We're going to do a deeper dive onto this. We draw this vertical line because we want to see you to the right of the red zone. This test is scored in relation to men your age. And we view this as 2 parts, a hardware component and a software component. And they both are very important. But we start with a hardware section, how you're doing cognitively, your focus, your memory, your processing speed. And I doubt that any of this is a surprise to you.
Just a minute, please, because somehow I lost this screen. I lost the ability to see anything. It says done speaking, like I'm muted or something. I don't know. Okay, I can see you now.
Okay, can you see my screen?
I can. I was trying to rotate my phone so I could read it, which I can't, but something happened. I'm back. Okay. Sorry about that.
No worries. So none of this should be a surprise. Cognitively, really struggling. Memory is off. Your focus is very poor. Planning's kind of middle of the road. Processing speed and recall memory are both very low. And I suspect that the reason that your planning and flexibility aren't as low is because you have what we would call a good amount of brain reserve or pre-morbid functioning prior to the traumatic brain injury. I mean, you've been successful, you've been engaged, intellectual, intelligent, so you have more of a reserve.
Yeah.
But, I mean, none of us are immune to biology and head trauma, and it's clearly impacted significantly your memory and your focus.
And had you tested me 6 months, I would have failed that. I wouldn't have been able to answer a single of those questions. I wouldn't have been able to draw a line between 1 and A and 2 and B.
Right. And had we tested you before your head injury, then it's a completely different issue as well. You're all in the green zone. So no, we always have to look at the context and how it correlates historically. And I'll give you a sense before we go any further.
Yeah.
When I look at these evaluation processes, my process is I start with an earnest review of the biopsychosocial spiritual history. I look at every detail there. Then I look at the total brain report. Then I look at the Connors test. I'll look at the SAGE test. And I also then look at the scans. Scans are the last thing I look at. I compare my findings to what the scan readers find because they get access to some slices that I don't see. Because you don't want to be inappropriately biased. And oftentimes, most of the time, these evaluations, very few things are a surprise as we go through it. Sometimes there are things that, hey, I would not have expected this, or this looks a lot better, but it really tends to either whittle down the differential diagnosis, or we always say the benefit of looking at the brain, looking at the organ you treat, is it helps us make better decisions and ask better questions.
Yes.
So then we look at the software component of your brain, which can be just as important, if not more important, than your overall hardware. Because your software component really reflects your emotional processing of things. Are you stuck in some negative thought loops? And we start with this conscious negativity bias here, which essentially refers to a filter or a lens in our brain that we all have through which we push perceptions of ourselves, other people, and our experiences in life. You see the glass is half empty or half full. And essentially, when we see patients with a very strong negativity bias, and yours was pretty strong, they're often generating a lot of automatic negative thoughts. Their filter is distorting their experiences to where they may see all the negatives and none of the positives. They may make mountains out of molehills or personalize things that aren't about them, or engage in what we call negative forecasting or catastrophization, expecting the worst possible thing to absolutely happen. And this isn't static, this can move. And usually when we see it this far to the left, we recommend cognitive behavioral therapy, which is evidence-based treatment, which really helps decouple the link between the automatic negative thought and the emotional conditioned response, which is usually fear-based and anxiety-based.
Yeah.
Tends to derail patients. And this is not surprising at all. I mean, almost every time I see one of these patients, your mood control almost always parallels where your negativity bias is. In your particular case, this was actually a little bit of a surprise. Depression's better than we would have expected. Pretty anxious, I mean, kind of goes right in a straight line, but your overall feeling of stress control is exceptionally low. And this was a little bit of a disparity too, if we point there. Your resilience actually doing better than we would have predicted with your negativity bias. So some of that may have to do with what you feel your support system is or how optimistic you are about your recovery.
Yeah.
So some things to work on, but that's why we look at all of the data and we don't look at anything in a vacuum. I'm going to bring up your Connors test. Do you remember when you took the concentration scan and we made you sit in front of the computer and the X would come up on the screen and you had to hit the space bar?
Yeah. I felt I felt a disconnect between my brain and my motor skills.
Yeah. Well, it's interesting. We do this for two reasons. One, it's a very sensitive test for attention deficit hyperactivity disorder. It measures 9 subscales of ADHD, such as impulsivity, attention, focus, concentration, perseveration. But we also use it as a cognitive stress test that when you are forced to concentrate, can you access your prefrontal cortex, the part of your brain kind of right above my eyeballs that is responsible for attention, focus, concentration, and being able to execute. Because there's a big difference between depression and attention deficit disorder, and we will see that on the scans. But when we pull up the CPT, this is, again, in relation to men your age, this scale is actually different. These are T-scores, standard deviations away from the normal. And in your particular case, this was not consistent at all with attention deficit hyperactivity disorder. I mean, the only area which was even statistically significant was that your reaction time was just a little bit slower than normal. And everything else, I mean, you had average ability to detect what the target was, what wasn't a target. You missed the target on an average basis, slightly above average, hitting the space bar when the X didn't show up. So you did better on this test than I suspect you would have expected. Not a consistent pattern of attention deficit disorder. That doesn't mean there aren't concentration and attention issues and memory issues as a manifestation of your head injury. But there are many comorbid conditions that can cause that. So I screenshot that, and I also screenshot this. And you'll get a copy of all the test results. Overall, because there is only one atypical
I will get copies of these items that you're showing. Okay.
The results do not suggest that Mark has a disorder characterized by attention deficits, such as ADHD. So, cognitively encouraging. And then remember the SAGE test, the test of your memory.
Yes.
You actually, it's scored on a 0 to 22 scale. Above 17 is normal. Yours was a 19. So yeah. So you did better on that.
I didn't feel that way when I was taking it.
Yeah. Well, and in a lot of respects, that's healthy, because when patients really have severe memory difficulties with consistency with a profound dementing process, they're not aware of the severity of their memory illnesses and issues. I mean, you're aware, but you did better on those things than you would have expected to. So now we're going to talk about SPECT imaging, and I'm going to give you an overview. I'm going to bring up this brain model, which you're going to see several times today. Your brain's only about 2% of your body's weight, but it expends about 20 to 30% of the calories used at any time. And about 20% of the blood that's being pumped at any time is going to the brain. So it's a very complicated organ with a massive caloric demand and a massive amount of blood flow. You've heard of CAT scans, MRIs. Those are structural imaging scans, very good at looking at the underlying tissue or anatomy of the brain, good at looking for fractures, bleeds, tumors, strokes. They don't show the underlying physiology of the brain like a functional neuroimaging scan. And SPECT is a functional neuroimaging scan. It stands for single positron emission computerized tomography. Basically, injection of the tracer is to see how your brain is being perfused. Because if your brain is not getting blood flow in certain areas, then those cells that are nourished by that area are essentially inaccessible or offline. And we always talk about the consistency of your brain. It's about the consistency of room temperature butter. And it's housed in this really hard skull. And the only thing that protects the brain from a skull, cushioned by a little bit of cerebrospinal fluid, which bathes the brain and spinal cord, as well as these three membranous layers, the meninges. But it's in a hard skull. And we always say you don't have to have a loss of consciousness to have a traumatic brain injury. Well, you've had obviously a significant brain injury. You think about it, if you hit the front of your head, well, the prefrontal cortex usually is impacted by the front of the skull. And you get a whiplash injury, your cerebellum and occipital lobes here in the back, at the back of your skull. And then your temporal lobes here in the middle, kind of about where my glasses frames are, in the middle cranial fossa. They are very important for housing the memory centers as well as mood centers. And they sit on this really jagged bone called the sphenoid wing. It's got ridges, jags everywhere. You actually ran your finger across it, you cut it on a skull model. So your temporal lobe is very susceptible to any sort of head trauma. And that's why your memory is very susceptible to any sort of head trauma. So when we look at SPECT imaging, we do it in two ways. We take a three-dimensional surface view of the neocortex to get an overall sense of what your brain health is like. And then we do a deeper subcortical view when the tracer gets into the blood flow deeper in the structures around the thalamus and the basal ganglia that you don't see on the outside, to get a sense of emotional areas. Because if your brain is getting too much perfusion in certain areas outside of the prefrontal cortex and the cerebellum, it has to pull from those other areas. So all this will make more sense as we go through it. And then we'll give up brain systems handout, and I'll annotate some findings and concerns that we've seen. So I'm going to bring up an example of a healthy surface scan. This is the camera looking at the outside in three-dimensional view of the brain. And I always start with the bottom right corner here. I think it's just easier for orientation. This is if the camera's looking down at the top of your brain. Yeah. The frontal lobes in the front, and then the occipital lobes in the back. And then this top left corner is the underside surface view. Camera's kind of looking up at the brain. Shows the inferior orbital prefrontal cortex, your temporal lobes, which here are nice and convex and symmetrical, and your cerebellum in the base and back of your brain. And we're going to talk a lot more about the cerebellum in a little bit. So color does not matter on the surface view of the SPECT. It's irrelevant. What we want to see is symmetry and smoothness. We don't want to see a lot of bumps. We don't want to see a lot of cracks. We don't want to see a lot of divots. So I'm going to bring up an example of a toxic scan for your reference. This is not your scan. It shows what we don't want a scan to look like. And I'll move this over here. I'll screenshot this. You see these holes up here in the inferior orbital prefrontal cortex?
Yes.
These are not physical holes in the brain. These patients don't have Swiss cheese in their brain. Again, what SPECT measures is relative regional blood flow.
Yep.
And when we see a hole on a surface view of SPECT, it means you've got to have at least a 45% reduction in blood flow to that area to show up as a hole on SPECT. So again, if that area is not getting blood flow, it's essentially offline. Those cells just aren't being nourished. And when you look at these really nice convex symmetrical temporal lobes here, they are chewed up on this toxic scan. It's almost missing here on left underside view. Certainly somebody's going to have difficulties with memory and mood. Maybe this is a frontotemporal dementia pattern, actually. And then you see how bumpy it is on the right compared to the left?
Yes, I do.
That's what we call scalloping. It's like somebody took like a russet potato and they just kind of bounced it on the ground a few times. It gets all bumpy. When we see scalloping, it's a sign of typically one of 5 conditions in the brain. One can be from a dementia process, Alzheimer's, vascular dementia, frontotemporal dementia. 2, head trauma. And again, you've had a significant history of head trauma. 3, inflammation, which can be from pro-inflammatory diets, autoimmune diseases. 4 can be from lack of oxygen. The umbilical cord is wrapped around your neck during child delivery, attempted carbon monoxide poisoning. We see it often in sleep apnea. So a little foreshadowing, you can rest assured I'll be recommending a sleep study as we go forward. And then often from toxin exposure, which can be involuntary toxins like exposures to chemicals in the workplace, solvents, pesticides in the environment, or in a lot of my patients, voluntary toxins, alcohol, nicotine, recreational drugs. Bad for them. So we want to see smooth symmetry and no holes or cracks or divots. And I'm going to bring up your resting surface scan. So as a doc, when I look at the surface scans, my 30,000 foot view is, am I seeing a really healthy brain or am I seeing a brain that's got some areas of difficulty? Yours kind of fell into that latter category. But again, we always say you're not stuck with the brain you have. Try and identify the issues and make it better. Your inferior orbital prefrontal cortex really offline.
Yeah. From my brain.
Lobes, yeah. Yep. Your temporal lobes certainly lacking. And your memory centers are in your temporal lobes.
Can you repeat that, please?
Yeah, your temporal lobes are lacking in perfusion. Your memory centers are located in your temporal lobes.
Okay.
And cerebellum's a little bit off. Really see some decreases in the posterior part of the temporal lobes as well. There's a little bit of scalloping. Actually, not that bad considering the extent of your head injury. Let me make sure that we stop annotating so I can keep closing out these things. There we go. Yeah, scalloping wasn't too bad. There's a little bit, this is what we call a little bit of a saddle sign here, where we see a little bit of drop off in the occipital lobe, almost like a shelf. And often we see that with sleep apnea, which is another reason we'll get a sleep study ordered. So, not too surprising based on your history. And I'm going to bring up
given my history and seeing what you see in the frontal lobe, normally you could contribute that to the head injury. Attribute that to the yes. Yep. Okay.
Absolutely. And it's going to be interesting. I'm going to bring up your surface scan when you were forced to concentrate, because I found this very interesting. this over there. Your prefrontal cortex fills in more when you concentrate. So do your temporal lobes.
Interesting.
Yeah, and so this is one of the things that we really find useful in differentiating between true attention deficit disorder and depressive disorders, thought disorders, because when patients with true attention deficit disorder are forced to concentrate, their prefrontal cortex actually goes offline.
It gets worse.
It gets worse. But when patients have mood disorders, depressive disorders, anxiety symptoms, and they are forced to concentrate, when they're forced to concentrate, they show improvements in their prefrontal cortex and your temporal lobes too. So when you're forced to concentrate, you showed significant improvement, which leads me to believe that in addition to the head injury, that unsurprising if you consider the amount of stress and the experiences you've had and, about the last 10 months or so, there's an underlying anxiety and mood disorder component.
Yes, I would raise my hand to that instantly.
Yeah, it's funny, when we always say the benefit of looking at the scans is it's important to look at the organ that we treat. And a lot of times when we do these scans, the patients they nod their head and they say, this is exactly what I've been experiencing. It's validating for them. And sometimes patients it kind of breaks through the denial. They're like, I'm doing okay. I don't have a problem with alcohol or drugs. And then they see their scans and it's like, well, your brain would beg to differ. So
I'm not in denial. That's why I'm here, because
it's obvious. Yeah, we seldom see patients that there's reticence certainly, and there's fear and anxiety about this, but we try and say you try and address each of the variables and try to get your brain as healthy as possible.
Yes.
So let me stop that annotation. I'm going to close that. I'm going to close that. And we're going to show the active view of the brain. Let me move this up here. Told you I'd be moving this around all day. So this is the subcortical view on SPECT, an example of a healthy active SPECT view. This is not the camera looking at the outside of the brain. This is when the tracer gets into the deeper perfused areas of the brain, the subcortical areas that you don't see on the outside. It's the same orientation, top down at the bottom right, underside active view on the top left, and then side to side views, which are really good at showing cerebellum, parietal lobes, and occipital lobes. So we told you color didn't matter on the surface scan. Color is what matters on the active view. It's not concentration, it's an active view. It's the subcortical emotional areas of your brain. And you see a lot of blue. We like to see a lot of blue in most areas of the brain. Blue refers to baseline, background, resting level of blood flow. Red is an increase in blood flow, usually up to about 80 to 85% of relative blood flow in that area to show up as red, which can be healthy in certain places. And then white, it's white hot areas on SPECT. White hot means that you've got to have about a 92% increase in relative blood flow to have a white hot area on an active view of SPECT. And say, okay, well, we've got white and red back there. Why is that healthy? That's your cerebellum. Your cerebellum is only about 12 to 14% of your brain's volume, but it contains almost half the brain's neurons densely packed into that small area. So about 50 billion neurons, which requires a lot of blood flow, a lot of oxygen, a high metabolic demand, which is why you want to see a lot of red and white in the cerebellum. If you don't see red and white in the cerebellum, you're going to have problems. And we used to think that the cerebellum was just responsible for motor control, how you coordinate your arms, your legs, your trunk when you walk, it does all of those things. But what we found in recent years is there's this pattern called diaskesis. It's a fancy word that means that even though the prefrontal cortex and the cerebellum appear to be anatomically unrelated, they're actually connected through intrasynaptic neural circuits. The cerebellum on one side, the brain connects to prefrontal cortex on the other side. Again, your prefrontal cortex is important for impulse control, inhibition, executing forethought, planning. Your cerebellum is like the clock speed on your computer. How fast do you think? The speed of thought. So we want to see a very active cerebellum. We don't want to see a lot of red and white outside of the cerebellum. Because again, if you've got more blood flow outside of the cerebellum prefrontal cortex, it's got to essentially pull from those areas.
Yeah.
And it'll make sense through our brain systems handout. So now let's look at your active view and we'll make a comparison.
That's quite a bit different.
It's quite a bit different. Yeah. When I look at the scans and the surface view, I'm thinking healthy brain, unhealthy brain. When I look at the active view, I'm thinking calm brain or really emotionally overactive in a lot of ways. And yours was pretty emotionally overactive.
Emotionally overactive. Yes, I can see that.
I'm going to go through each of these areas. We'll annotate this. See, your cerebellum is just not as white as I would like to see across the board because you've got white in all of these areas, and we'll go through each of them. ACG stands for your anterior cingulate gyrus, BG for your basal ganglia, and deep in the midbrain is your thalamus. I'm going to bring up our brain system handout now. We'll go through each of these areas. We'll start with the prefrontal cortex. We had seen that your inferior orbital prefrontal cortex was kind of offline at rest, which leads to difficulties with impulsivity, disinhibition. Your dorsolateral part of the prefrontal cortex, which was a little offline, difficulty with attention, forethought. Now, again, you don't have attention deficit disorder. You've had a head injury with some resulting cognitive difficulties and difficulty focusing. But the mood component is clearly impacting your ability to focus and concentrate as well. And what do we often see? Patients that have difficulties with the prefrontal cortex, ADHD, brain trauma, depression. I know you don't have a personality disorder because having seen thousands of patients for almost 3 decades, I would have picked that up in about 35 seconds.
Yeah.
We don't see a lot of patients with personality disorders at the AMN clinic.
So would you attribute most of that to the brain injury?
Yeah.
Okay.
In your particular case. Certainly
Yeah.
the etiology of it. But I think that one of the things we're going to see as we get into the basal ganglion thalamus is that the mood difficulties that you are presently having are making that worse.
I would not be surprised.
Yeah.
Yeah.
We're going to go to the anterior cingulate gyrus, one of Dr. Amon's favorite structures. Runs on top of your corpus callosum, the area in the brain that separates the hemispheres. Starts here, goes to the middle. This is the posterior cingulate. The anterior cingulate gyrus is your brain's gear shifter. It allows you to move cognitively, flexibly, and emotionally flexibly. Yours is a little overactive. It's not white hot. Sometimes when we see elevations in the anterior cingulate gyrus, what we often see is patients get stuck. They can't move. They can't shift their thoughts. It's like the gear shifter on an old standard transmission. It's grinding. And patients can have difficulties with obsessions, flexible worries. We see this with obsessive compulsive disorders. We see this with anxiety disorders. And then we'll do a little geometry down the road. We'll see if I can remember my 9th or 10th grade geometry class. Basal ganglia, white hot in your particular case, especially on the right side. Your basal ganglia contains several nuclei. One is the nucleus accumbens, which is the pleasure center in the brain. When we see patients that have significant alcohol or drug problems, it fires off all of this dopamine and the nucleus accumbens. Patients crave more dopamine. They get more anxious. Their prefrontal cortex drops. Well, fortunately, I don't have to worry about you having addictions. What we do see is you've got significant anxiety. Your caudate nucleus is responsible for maintaining one sense of calm. And when that gets off center with too much activity, patients tend to feel anxious, panic. And then I always, when I see the overactive basal ganglia, I go back to their negativity bias on the total brain. When you've got that negative filter, you create a lot of automatic negative thoughts, which often leads to catastrophization or predicting the absolute worst possible thing is absolutely going to happen. So we see this with anxiety disorders, and this is why when we talk about treatment of anxiety disorders, before we talk about supplements or medications, at least in my case, I always talk about the importance of cognitive behavioral therapy.
Yes.
So we'll get to that in our recommendation section. And we go to your deep limbic system, your thalamus. This is responsible for several things. It's your mood manager, but it's also an important relay station. Pain impulses from outside of the brain and spinal cord travel through peripheral nerves into the brain, spinal cord, up the brainstem, and they merge in the thalamus. Your thalamus sends projections to other areas of the brain so that your brain can recognize spatially where that pain is being felt. When we see patients with increases in the thalamus, instead of having level mood control, what do they typically have? Significant depression, significant sleep and appetite issues. Your hypothalamus is right below your thalamus, has a number of receptors important for sleeplessness, wakefulness, connections to the suprachiasmatic nucleus. And we see this often with pain conditions and depression. And none of this is a surprise in your case.
So when you say pain conditions, like long-term pain,
yep,
is referring to. So I have a long-term back condition, several disc herniations, that have caused me a great deal of pain over a long time period. Yep. So
not surprising. And you combine that with a depressed mood, and I mean, I would have been shocked if your thalamus wasn't overactive.
Yeah. So I mentioned this to the interviewer, but I survived. My brain injury resulted from my drunken spouse, and I survived a very long, difficult relationship with her alcoholism and drinking that put me honestly on edge and at fear at all the time, because I was there to protect my children, and I felt it became a pattern that I could not escape without leaving the house and subjecting my children to her abuse.
Yeah. Well, and that's interesting because this is where the geometry comes into play. When we see patients that have this anterior cingulate gyrus, basal ganglia on both sides, and thalamus in the middle, if I connect that, it's not as symmetrical as my baseball coach would have liked, but that is our diamond pattern. And we see that often in patients with post-traumatic stress disorder, exposures to emotional trauma, which can be from one big T trauma or a series of repetitive emotional traumas over the years.
And I was I've seen a number of clinical psychologists over time, one for a 15-year stretch, and he did diagnose me with post-traumatic stress disorder from the and from this head trauma.
Yep. And it's interesting when we do these evaluations, we kind of, before we see the patient, after we've gone through things, we put down what we think are possible diagnoses. Guess what's down on yours, on mine? Traumatic brain injury, anxiety, post-traumatic stress disorder, depression, sleep apnea. So
yeah, there you go.
This is a surprise. And the difficulty with post-traumatic stress disorder, it's kind of this fight or flight reaction. We show this model,
right?
Your brain gets activated, you're in the fight or flight mode, which is important. You need to know what's a threat. But you also want it to be able to relax and calm down so you sleep at night. And when you get repetitive trauma, you get stuck. That creates a lot of cortisol. Cortisol is a stress hormone important for metabolic regulation, electrolyte regulation. The difficulty when you have chronic cortisol levels is you start to have more anxiety and depressive symptoms, and cortisol is destructive to cells in your hippocampus. Your hippocampus is in your temporal lobes. It's where you consolidate new memories. And we've seen the temporal lobe dysfunction on your surface scan. So none of this was a surprise. You're having difficulty with memory. The traumatic brain injury is causing that, but also the post-traumatic stress disorder worsens that.
Yes.
Because all of that cortisol makes it difficult to calm down.
Yes.
So let me screenshot this. Let me clear these drawings. And let's talk about what all this means. So again, my responsibility is to tell you what I think is going on diagnostically after I assimilate all the data. Sequence treatment recommendations, and I'm meticulous from going from most conservative to most aggressive options. Provide you a menu of reasonable options, answer what questions you have, and then ultimately support what decision you're comfortable with. You don't have to make any decisions today. I've been doing this a long time. My pulse needs to stay 50. I want my patients to be patient with the process. You didn't get this way overnight. It doesn't get better overnight. But we've talked about what's going on diagnostically. Post-traumatic stress disorder, the head injury, the anxiety, the depression, sleep apnea is exacerbating this, the Meniere's disease, the tinnitus. So how do we treat it? Well, we start with more conservative choices before we go to moderate and then intense interventions. And you'll get all of these sequenced in my next steps. First thing, you have had lab work done recently, which is all essentially normal, correct?
All essentially normal. That's correct.
Okay. I checked that box off. The second thing, diet. You have a diet that's healthy, keto diet, correct?
That's correct. I've lost 70 pounds in the last 2 years.
That's great. So you're 2 for 2. Keep this up. You're going to be in Cooperstown. Be there before Pete Rose gets in. Next area, exercise. You can't exercise too much. And I know with some of the physical pain that you've had, that may be difficult, but we're always talking about having some combination of aerobic activity to calm the thalamus, as well as increase blood flow to the prefrontal cortex, and as well as some resistance strength training. Nobody expects you to be a Mr. Atlas, but when I see patients that have joint issues and stuff, one of the best, healthiest things for them to do is water aerobics. If you just get in a pool with a flotation device and you just move around, it gets you some cardio work, but it's very helpful for your body. It's a form of resistance training that's just, I'm convinced swimming is the fountain of youth. Ponce de Leon had it somewhat right. He should just not have gone to Florida to try and find it. I don't know you ever want to go to Florida for anything. And my parents live there, so you can have that state. Next area, sleep study. I'm pretty sure you got sleep apnea. I need to get a sleep study on you. Because if you've got 6 to 8 hours a day where you're not getting enough oxygen to your brain, hard for your brain to heal. And sleep apnea is treatable. Sometimes it doesn't even take a CPAP or a BiPAP mask. Sometimes it's just tongue positioning. It's a mouthpiece. It's an airflow issue.
Okay.
So we'll get that ordered. Therapy. Cognitive behavioral therapy. Evidence-based treatment to treat anxiety, depressive disorders, trauma-based disorders. It is proven effective in those disorders, and it has been underutilized in the past 3 decades of the biologic revolution in psychiatry. Because all we focused on is medications, and we've done patients a disservice. Cognitive behavioral therapy is critical for several reasons. It helps decouple the link between the automatic negative thoughts and the fear-based emotions that are conditioned. It helps with the anxiety, the trauma, but just as importantly, you gain tools that allow you to have this internal locus of control. As opposed to relying on a pill, it's something that you control.
Yeah.
And that's where psychiatry has done patients a disservice. It's like, okay, symptom pill. There's no pill for the treatment of life. So.
Agreed.
Now we get into moderate levels of intervention, supplements versus medications. I view them on a continuum. I try and treat them in the same way, manipulating the fewest amount of variables as I can at once. We want foundational supplements on our patients, multivitamin, omega-3 fatty acids, enough vitamin D3, And full disclosure, before we go any further, if I recommend some of Dr. Amen's supplements versus anybody else's, I'm getting kickbacks for recommending Dr. Amen's supplements. I like his because they're well-researched and broad-based. The argument for supplements versus medications is they're natural, they're better tolerated, they have less interactions, less side effects. Medications may be more aggressive, more pinpoint. We did a study of 100 retired NFL players who can imagine just had bashed brains. Put them on a robust Neurovite along with memory power boost, which helps with ginkgo, helping increase blood flow to the brain, helping with huperzine A, a precursor for acetylcholine, one of the major neurotransmitters in the brain, phosphatidylserine, alpha-lipoic acid, helping to stabilize cell membrane function. That's why patients need a lot of omega-3 fatty acids too. You need a lot of healthy fats for cell membrane function, neuronal function. So we put patients on a robust brain and body power max. Anytime I see somebody with brain trauma, memory issues, temporal lobe dysfunction, that's always a supplement I recommend. It's robust.
I realize that what I've done wrong over the years. Yes, in that regard.
Yeah. And then we look at symptom-based supplements. How do we get the anxiety better treated? How do we get the thalamus and the basal ganglia to calm down? Well, often when we see thalamus issues and basal ganglia issues, we are often looking to calm those overactive areas with something like GABA calming, which is a primary neurotransmitter in the brain that's inhibitory. I use that with a lot of patients. Sometimes I'll use everyday stress relief, which also has magnesium, some vitamin B6, and theanine. Theanine is really taking off. It's this amino acid that helps increase the alpha brain waves in our brain. They're the brain waves that when we close our eyes and relax, they move from the occipital region to the prefrontal region. So those are a couple of supplements from a symptom-based standpoint to consider. I usually don't start patients on more than 2 to 3 symptom-based supplements at once. And the third being if I put them on something like Put Me to Sleep Naturally, which has some theanine, some melatonin, GABA, vitamin B6, magnesium. I recommend Put Me to Sleep Naturally for just about every patient with sleep issues. It has minimal dosages of melatonin, but it was created by a sleep medicine expert, Dr. Criado. The theanine really helps patients fall asleep faster. You stay asleep better. They don't have daytime hangover effect. It's not addictive. It's not a benzodiazepine. So that's certainly something to consider.
Okay.
And then medications. Would we go with medications before supplements? Some people want to. When we see significant overactivity in the basal ganglia, the thalamus, and the anterior cingulate gyrus, we're often thinking, does this patient need an SNRI like Effexor, an SSRI like Prozac, Lexapro? Effexor is a very helpful medication if you can tolerate the side effects. And a lot of people just can't tolerate the side effects. I use a lot of SSRIs to help calm anxiety down. Not as specific for the thalamus and maybe not as great for the basal ganglia. That's why we often look at the everyday stress relief before we look at something like serotonin mood support. But those are considerations. And then the more aggressive options, downstream options. Neurofeedback, which is critical in helping calm down the temporal lobes, improve the focus in the prefrontal cortex. It's an underutilized resource. We do it with QEEG monitoring, looking at the electrical activity in the brain. When I see patients that have temporal lobe dysfunction as well as anxiety, I always recommend neurofeedback, but I always have that downstream because I want them to do CBT first. I want them to fertilize the ground. It makes the neurofeedback more cost effective and it's a much more seamless process. And then the most aggressive option we often get with patients that have traumatic brain issues is hyperbaric oxygen therapy. I guess it's most aggressive maybe because it's most costly, but it's from an interventional standpoint.
Yeah. Is that effective? I understand. I'm just my understanding. I'm asking for clarification that was quite helpful with a new injury or a current injury, not helpful with something like mine that's 15 years ago. True or not true? That's all my my question.
No, I don't think that's true. I think that what we've seen is there's been research that's done that suggests that it helps with cognitive dysfunction, regardless of it's from a dementing process or traumatic brain injury, or how much of it's toxicity, how much of it's toxin exposure. I mean, there's 13 FDA indications for HBOT at this point in time. Dr. Amon's done research which has shown it's helpful and helpful with traumatic brain injury. Usually it's 15 minutes twice a day for 30 days. It's gotten so popular and well researched that what we actually see now is patients are not going into the clinics as much for HBOT. They bought their own soft shell at home HBOT chambers, which over the long run is very cost effective for them. They can get in it every day if they want. To the point where there's not just with supply chain issues, but the demand and supply chain issues. It's hard to find an HBOT soft shell chamber at this point. So again, you're not stuck with the brain you have. The fact that you've lost weight, that you are on a healthy diet, you're doing a number of things. It's how can we try and get you optimized? I mean, what I tell patients is you spend a lot of time and money when you come to the Amen Clinic. We want you optimized. We don't want you to just get 20 or 30% better. So we address every variable and view your treatment comprehensively in the old pie chart. If therapy helps 10%, if exercise helps 15%, you're just trying to add the best percentage chances for you to get improved and optimized.
Yes. Very good.
So I've thrown a lot at you. What I'm going to do now is I'm going to get my recommendations to my medical assistant, finish up with your final report. I'll get sleep study referrals made, cognitive behavioral therapy referrals made. I've got a significant amount of work to do, but do you have questions for me before we go forward?
So I have questions about going forward.
Mm-hmm.
So will you be available for additional consultation or questions, obviously for you personally?
Yeah. So what happens next is I send this to my patient care coordinator to do all of the busy work. A patient outcome manager speaks with you usually within a couple of weeks to make sure, did you get the report? Did you get the screenshots? And how are you doing on these things? The supplements start. And then typically with the evaluation package, you have 2 follow-up visits with me. I usually see people, 4 to 6 weeks after the first evaluation. And in some patients will continue with additional sessions after that, depending on the personal situation. So, but I'm very accessible. I mean,
great. That's all I needed. That's what I needed to know. Because obviously, I know my processing's slow, and I obviously will be going through this and processing this, and I will have a list of questions, or that it would obviously be better if I could speak with you at some point. Yes.
Yeah, and that's why it's helpful, because you'll get this comprehensive report. You'll get my next steps recommendation. You're going to get so much data. You'll get the screenshots, but the Zoom link recording that you're going to get sent, I would probably, today's Thursday, I'd watch it on Sunday. Give it a few days to marinate, and then you look at it, it's like it crystallizes what we talked about today. It helps you process more than what you're able to process live, because you just get so much information.
And I download and keep that recording of our meeting.
So what they, because this question comes up all the time, and what they recommend most people do is that when you look at the recording, you record it on your phone. So that because the link expires within a couple of weeks. We've talked with I'm not an IT guy by any stretch. So I tell people, if you can put a man on the moon, can you figure out something? And
okay.
When the tech people start talking to me, I just kind of zone it out, because they're sometimes they really want to get on this.
No restriction on your part of retaining the recording if possible.
Right. So that's why we say, when you get the link, turn on your phone and record it.
Yeah. Got it. Very good. Thank you very much. I really appreciate time and input today. It was illuminating. Again, most of it suspected.
Sure.
So just wanted to touch on one more quick thing. So did you see any evidence that you would point to solvent damage, brain damage from my?
You know, it's interesting when we see solvent damage, often on a spec, it's kind of non-specific. It's sort of that toxicity, that scalloping. And you didn't really have a lot of scalloping. You had some sleep apnea issues. When we see a lot of solvent damage, where I see it's on MRIs and the white matter, because the people that I see that have some of the worst brains, not just the worst brains, but the worst presentation psychiatrically, cognitively, are the kids that are huffers, that have just used solvents. And if you look, it's just so destructive to their white matter. Their MRIs look terrible. And their presentation is, it's like they have a combination of the most severely disorganized schizophrenic, and disorganized schizophrenia is the most difficult subtype of schizophrenia to treat, as well as the cognitive difficulties of someone with dementia. I mean, they're I just always considered it phenomenologically, like it's like they've got jelly brains at this point. So solvent exposure is awful.
You didn't see much evidence of that. I just only because early in my business, the name of my business is Meticulous Manufacturing. I'm a very meticulous person, but I was in early days, I was doing a lot of the product painting, which was automotive paint. A lot of those solvents are gone. And I was always careful, just wanted to make sure. I was always wondered. That's all.
Yeah, it's interesting when we see patients that have worked in furniture factories and stuff, and oh my gosh, their specs look just awful. So, that's the thing. I mean, your surface scan was concerning, especially in the temporal lobes, cerebellum and prefrontal cortex, but it wasn't as bad as I would have expected, actually.
That's good. I just clarify.
Yeah. So, and again, you're not stuck with the brain you have. So, I think that there's every reason to believe that this can get better, and it's just trying to address every variable as systematically as possible.
Right. One more question, I'll let you go. So previously in my MRIs and CT scans, they've noted every single time of the subbasal ganglia calcification. What impact? Nobody could really ever place a significance on that for me.
Well, it's interesting. The basal ganglia has the nucleus accumbens, the putamen, which is more motor related, and the caudate nucleus. So the fact that, we haven't really seen a lot of specific motor difficulties in your case that couldn't be attributed by the neuropathy.
They could.
And how much of the anxiety is related to that basal ganglia calcification. And when you think of calcification, you're often thinking of something that's rather fixed as opposed to fluid with blood flow.
Well, right. Just searching for your opinion on that. That's all.
Yeah. So the question is, does it potentially add some motor difficulty? Yeah. Is it potentially adding some anxiety difficulty? Yeah. I doubt that it's the primary source at this point. If you look at the amount of blood flow going to that basal ganglia, it's pretty extensive. Yeah.
Mostly the head injury, correct? As you would see.
I think the head injury and the subsequent anxiety and depression. Again, I think that if we had done this evaluation, say, before last October, maybe it's a different narrative. But I think that everything that you've gone through since has exacerbated that anxiety and mood difficulty, and then made it more difficult to concentrate. So, yeah.
All right. Thank you very much.
It was a pleasure. Pleasure meeting you, Mark. I'm greatly looking forward to working with you. I'll see you down the road, and if you need anything before then, just let me know.
I will. Thank you very much. I'll contact you through care coordinator. Okay.
Okay. Take care, Mark.
Thank you. You too. Have a great day.
Bye.